Is there any questions from material from Tuesday? You guys are up on the kidneys. You guys are well versed in it. Hopefully, maybe. Okay, at least we're being honest. Some people, that's good. Okay, so we're gonna continue on. This will be the last section for section 3, or last unit for section 3. So we're talking about urology. We'll start out with something very awkward. So we'll do erectile dysfunction first, which could be pertinent. You know, if you guys are doing trauma sims today, you can certainly see that potentially relate back to trauma. So basically what we're going to be defining this as is going to be persistent failure to achieve an erection for the purposes of intercourse for at least 3 months, also just known as impotence. Basically this is different than things like decreased libido if you have like an ejaculatory disorder or infertility, right? So for instance, when you have a patient who is on like an SSRI, something like citalopram, something like that, and they are unable to have an orgasm, like that would be a different treatment pathway than you would see for something specifically like this. So again, it's important to kind of get down what exactly is the problem with the patient before you decide what kind of drug therapy is going to be good for them, right? So you typically see this increase in incidence as you get in older ages. Usually it's pretty low in ages less than 40, and around a third of men between 53 and 90 years of age end up developing this. While it used to just be part of the aging process, now we have pretty good medications in order to treat this. But you will see it more likely to occur in patients who have things like hypertension, arteriosclerosis, hyperlipidemia, diabetes, etc. So this can be a very common comorbid condition with a lot of these other conditions, especially medications. We'll look at some of the medications that can be involved in influencing this and potentially exacerbating it. So how does an erection occur? Well, this is through the corpus cavernosum, and basically we have pretty balanced flow through the penis during a flaccid state, but when you end up having an erection, basically you have the venous outflow is going to be constricted. And that way the blood kind of can come in and it'll get stuck there, and that's where you lead to the erection. So we'll look at if we have kind of dysfunction in this, we can give medications that will help regulate this a little bit better. We'll look at specific medications that do this. So basically looking at the arterial flow, what is influencing this is going to be through this acetylcholine-mediated vasodilation. Basically, you guys remember second messengers, remember cyclic GMP? You guys remember where LSAT is very prominent at? Remember, cyclic GMP is very prominent with things like nitroglycerin and affecting things like vasodilation and affecting blood pressure. So that'll be really important when we're talking about drug interactions and we're talking about other side effects you can see with these medications. Cyclic AMP is also involved here as well, and there's also this vasoactive intestinal polypeptide that is mediating this vasodilation. And basically what we end up seeing is that nitric oxide stimulation will end up leading to increases in cyclic GMP. You can go back and refer to that kind of diagram, see how that works. That will decrease calcium in that vascular smooth muscle, and that leads to this vasodilation. It allows for more blood flow in, and that will lead to the erection. And then you'll see that things like acetylcholine or prostaglandin E will enhance cyclic AMP from that pathway, so that will be important. We're talking about other modalities for treatment of erectile dysfunction. So as far as psychogenic stimuli, obviously you have to have some sort of external stimulus in order to achieve an erection. So this is mainly carried through the sacral nerve reflex arc. Basically the nerve impulse is carried down through the spinal cord, which is why you see problems with trauma patients end up having this can occur, can be disrupted, especially with spinal cord injuries. And then also another really important thing here is the hypothalamus is responsible for kind of integrating these external stimuli with these kind of nerve conduction pathways. So things like dopamine can exert a pro-erectogenic effect. So that's kind of one interesting neurotransmitter there. But also alpha-2 stimulation inhibits erection. So you guys remember any drugs that affect alpha-2 receptors? So things like clonidine, things like guanfacine. Remember those drugs affecting that presynaptic alpha-2 that actually decreases catecholamine release. But so you can start to see some of the medications that may actually be involved with this and lead to inability to achieve an erection. And then detumescence is going to be mediated by norepinephrine. And so basically by contracting down on the vascular smooth muscle, that decreases the arterial flow, and then your venous outflow is also going to increase. And so that will be important if you were ever to treat what do you call like an extended erection that does not go away? Yeah, priapism, priapism. So how do we normally treat that? Does anyone know? You could drain it. If that doesn't work, what else could you do? you can actually use phenylephrine. So phenylephrine works very similar to norepinephrine. It's a pure alpha constrictor, and so you can actually give that intracavernosally, and that will actually constrict down and lead to less blood flow coming in, and that way it'll kind of balance things out and allow for detumescence to occur. So also another drug you may never see being used, but it has some evidence for use, is methylene blue. It actually also has some vasoconstrictive properties that can be useful for that. So sometimes that will be used. But we know there's hormonal effects that are involved here as well. So testosterone is going to be the big one. Obviously, as male patients get older, they're going to have gradually decreasing amounts of testosterone being produced. This is important because it stimulates the libido. So without stimulation, may not be able to achieve erection. And another important enzyme that is responsible for kind of pro-androgenic effects, we'll talk about this more when we get to like BPH. It's going to be this 5-alpha reductase enzyme, and that's responsible for converting testosterone over to dihydrotestosterone. This will also be important because it stimulates growth of the prostate, which again we'll look at a little bit later. Of course, some of it will get converted over to estradiol, which can lead to things like pro-estrogen effects like gynecomastia. And it's really you have to be careful when you're interpreting testosterone levels in those patients with erectile dysfunction. So could be totally normal for those patients. Sometimes you have to look at free levels to see what specifically is physiologically available for the patient, and kind of differentiating between is the patient just having decreased libido versus true erectile dysfunction, because obviously your therapy is going to be changing between those two. So looking at other causes for this, so you can have vascular issues coming about here. So if you have peripheral vascular disease or arteriosclerosis, that could be one issue leading to erectile dysfunction. We mentioned the spinal cord injury, but certainly things like stroke and diabetes. Why do you think diabetes can affect this? Circulation. Could affect circulation. What else? Nerves. Small vessel damage. You said the nerves. All right, so you can see neuropathies that can come about from this as well. So again, that could be one of the pathways there. And obviously with hormonal effects of aging, testicular removal, so if there was previous history of testicular cancer, hyperprolactinemia can be big here as well. So again, all those things can be playing a role. And just kind of other causes, about 80% of it will be related back to that. Certainly there is psychogenic erectile dysfunction could be more related to the patient and how they're kind of interpreting things, and related back to psychiatric history and things like that. Oftentimes you'll find that's multifactorial, so you kind of have to take it piece by piece and try to figure out what the different issues are and try to treat those appropriately. But make sure the patient has a proper frame of mind. A lot of cases, things like reactive depression can lead to this, and obviously if they have issues with depression and then they have erectile dysfunction, that's probably going to lead them to more depression, right? Performance anxiety, Alzheimer's disease can be a big cause for this, hypothyroidism or other mental disorders. So again, these are things to try to take care of individually before you jump straight to using specific drugs for treating the ED. So this is important, at least for our purposes here. So medications can be responsible for about 10 to 25% of cases, they estimate. So we mentioned acetylcholine is going to be really important for stimulating these pathways here. So anticholinergics can lead to this. So things like antihistamines. What are some examples of those? So generally, these are going to be your first generation antihistamines, right? Because we mentioned that your second generation drugs really lack a lot of those anticholinergic effects, so they don't cross the blood-brain barrier, right? So things like cetirizine, loratadine, fexofenadine, those aren't really going to be having this effect, fortunately. What would be some first generation antihistamines? Diphenhydramine, doxylamine, meclizine, things like that can all have those anticholinergic effects. Certainly, like things like anti-Parkinsonian agents, trihexyphenidyl, benztropine, things like that can do it. Tricyclic antidepressants, and then phenothiazines. So it'd be easy to see how patients like mental health issues would also be on some of these medications that could again exacerbate this. If you're looking at the drugs which can cause, for depression, which can cause erectile dysfunction, usually TCA is going to be worse, mainly because they have not only their effects with serotonin leading to sexual dysfunction, but also due to the anticholinergic effects. So these drugs are going to be the worst on this. SSRIs are going to be kind of second. SNRIs will be kind of second least offensive in this case, and then bupropion is always going to be the best for patients with sexual dysfunction, right? So that's always kind of your go-to drug for that. And then other things that can cause this include dopamine antagonists, so things like phenothiazines and metoclopramide. Again, those are probably the more common ones you're going to run into. So by blocking dopamine, you're going to see increased levels in prolactin and other things. So again, all of that can be kind of playing a role here. And again, having a high prolactin level will end up decreasing your testosterone even further. We know that has kind of pro-estrogenic effects for those patients as well. So anything that is antagonizing the effects of testosterone is also going to be affecting the libido component of this. So things like estrogens, anti-androgens. We'll talk about some anti-androgens just a little bit later. Spironolactone has some androgen receptor antagonism effects, and some other kind of rare ones you may not see as frequently, but things like ketoconazole, somatostatin, can suppress testosterone formation. And then obviously any kind of CNS depressant can affect this as well, just because if you're not really able to have that perception of the external stimuli, not able to really respond to it. So if someone was too CNS depressed to realize that someone was coming on to them, they would not be able to have the appropriate effect, right? So things like benzodiazepines, opioids, large doses of ethanol, anticonvulsants, all of this can potentially lead to issues with that, right? Then getting into the agents that can affect vascular blood flow, so looking at things like diuretics, beta antagonists, or central sympatholytics. So we mentioned clonidine, guanfacine can do this as well. If you're decreasing the amount of blood flow going to the area, then you're not going to be able. Then you're not obviously going to be able to achieve an erection. You see this less frequently though with things like ACE inhibitors, ARBs, and then calcium channel blockers. So if your patient had issues with this that developed right after they started a beta blocker, then switch them over to something like an ACE inhibitor. It might be a better option for them, mainly because it's just not going to affect the arterial flow quite so much. And then some other miscellaneous agents, we'll talk about drugs like finasteride and dutasteride. Those are going to be aromatase inhibitors, can be used sometimes for things like sometimes BPH, sometimes you'll see it used for things like breast cancer and whatnot. Lithium can have a problem with this, MAOIs, and then for some odd reason, Gemfibrozil, which you guys remember where we saw that before? Just hyperlipidemia. Yeah, it's one of those fibrate drugs. I don't know why it causes that. It just happens to be one of those kind of rare side effects you see with it. So again, always check the med list. Always check for things that could be interacting. Because this is going to be one of the easiest things to fix if you can, is to switch them over to something else or discontinue it altogether. Okay, so again, diagnosis should be doing a thorough history, looking at their medication list and other concomitant disease states to see what could be playing a role here, and then obviously looking at physical exams and their testosterone levels. So our goals here, we'd like to have improvement in the quantity and quality of suitable erections, have reasonable expectations of the patient as far as how well the drugs are going to be working, and then you really only want patients with legitimate complaints. So what do I mean by that? Exactly. Some people will use this as a performance-enhancing drug, especially if they have no actual issues themselves. So in a lot of hospitals, you'll actually find that these drugs, specifically like sildenafil and things like that, are actually controlled substances like opioids and things like that, because diversion by staff can be just as important of a problem as with opioids, right? They're not controlled substances by any means, but sometimes you'll have inappropriate use. So make sure the patient actually has a problem and not just coming to you like an 18-year-old guy, pretty normal, and be like, yep, I got some problems, and it's probably not the case really. So just make sure they have legitimate complaints. Again, we'd like the medications to be well tolerated. This will be important when we're looking at adverse reactions, looking at drug interactions, and they should also be a reasonable cost. You're starting to find that more and more insurances are starting to cover a lot of these medications, but back in the day, like, it used to be very, very expensive for some of these patients. So you'd have guys who would come into the pharmacy counter with their prescription, be for like a 30-day supply of sildenafil or something, and you come up Friday night and they'd be all kind of dressed to the nines and be like, nope, I only want to pay for one pill. That's probably all they needed for the weekend. But again, back in the day, it was way more expensive than now when it's being covered a lot more frequently. So obviously you want to treat and correct any kind of underlying disease states, so things like hypertension, coronary artery disease, dyslipidemia, diabetes. If you can affect any of that, that would be useful. Then also psychotherapy for any kind of psychiatric problems you might be having. And then we'll look at the different types of devices and medications we can use here. We're not going to go super in depth on things like the vacuum devices and surgery, but the pharmacologic therapy is going to be the most frequent ones we're going to be encountering out there. So the treatment for this, we should have pretty fast onset, should be efficacious, convenient, cost effective, right? That would be nice. And then we also like to limit our side effects and also limit our drug interactions. Generally, you want to try to use things that are least intensive or invasive, all the way up to things that are more invasive, right? So if you just pop a pill, it's going to be a lot easier than a patient having to get out like some big device to actually achieve erection, okay? It's going to be much more tolerated well by your patients. So basically, you can kind of follow these treatment algorithms. Here it's pretty straightforward. You start with a patient with erectile dysfunction you've diagnosed. You want to treat underlying conditions, remove medications that could be contributing, any risk factors, and then obviously if there are testosterone deficient, replace that where you can. Then we'll see the phosphodiesterase inhibitors. These are going to be things like your Viagras, your Levitras, things like that are going to be the first stop as far as treatment goes. If it's effective, great, keep on using that as needed. And then if not, then you can look at obviously, if the drug is having some effect, but maybe not as much as the patient wants, you can try maximizing your dose, maybe try switching over to a different medication. If a patient is contraindicated from receiving a phosphodiesterase inhibitor, it's important to remember who will be contraindicated there. That's where you can use things like a vacuum device, or potentially have, we'll look at some prostaglandins that you can actually administer. We'll look at how to do those a little bit later. And then you can look at things like surgical interventions at that point. Okay, so again, going from least invasive to more most invasive. So as far as, I won't kind of belabor this point too much, but looking at vacuum erection devices, basically there's two components to it. There is it's forming a negative pressure to kind of draw arterial blood flow into the cavernosa, and then you can kind of maintain that with things like constriction bands or rings. Pretty fast onset, and overall it's very effective, but obviously it's not very discreet, right? So patient would have to kind of go somewhere else, you can do the thing, come back and be ready to go. It's not as easy as just kind of throwing a pill in. These are good for patients who cannot tolerate phosphodiesterase inhibitors or PDE5 inhibitors or other agents, and then sometimes can actually be used in combination with other therapies prior to going to surgery, right? So we'll look at some of the surgical options, and obviously that being the most invasive one, we'd like to be able to use something that can be a little bit more reversible and a little bit easier to use. But we will be focusing on the pharmacologic treatment since that is most common. So basically what is happening here with the phosphodiesterase inhibitors, basically you have, starting out with sexual stimulation of the patient, you're going to end up releasing things like nitric oxide. Remember, nitric oxide is vasoconstrictive or dilatory? Dilatory, right? And so this is going to be released from the endothelial cells, and so that will stimulate guanylate cyclase, which is going to increase levels of cyclic GMP, and that will allow for vasodilation and allow for that increased blood flow. Now, normally, cyclic GMP is metabolized by the enzyme phosphodiesterase 5, specifically in, you'll see it used in the lungs and also in the penis. That is the most common place to find PDE5, and by inhibiting that with things like sildenafil, you are able to have higher levels of cyclic GMP for longer, and thus achieve and maintain an erection. So the phosphodiesterase inhibitors that we have available include sildenafil, vardenafil, tadalafil, and avenafil. Avenafil probably being the newest one out there. And again, these are actual analogs of cyclic GMP, and they not completely specific for PDE5. We'll see in some cases how these can affect other subsets of phosphodiesterase, but this is the main one we're looking at, is PDE5. But that can lead to side effects when you're looking at other types of PD that get affected there. But again, very frequently we'll use this as well for, because you have high PDE5 levels in the lungs, we'll also use this for, do you guys know what condition you might use it for? Yeah, pulmonary hypertension is a big place. So if you ever see us giving little girls or little boys sildenafil, it's mainly for their lungs more than anything else, right? So especially some of our cardiac kids that have pulmonary hypertension, you can give that, and it causes a vasodilatory effect there as well. You'll find, we'll talk about some of the other isoenzymes of that and where you find those. But here's a good table just kind of comparing some of the differences between the various drugs. You'll see that the PDEs that they are specific for is going to vary, and that will lead to different side effects. You also see that the kinetics of them change a little bit, so one might be better for for longer durations of therapy and things like that. So just kind of briefly going over this. We'll talk about specific side effects, but mainly you're going to see things like retinal changes. You'll see things like myalgias can be related back to PDE6, PDE11. So we'll look at how those are going to be affected there. Do notice that, so where's that? So actually plasma half-life is going to vary between the different drugs. You'll notice here things like tadalafil or Cialis has the longest half-life out of the bunch. So this is why I got marketing for, okay, you just take it on Friday and you're good throughout the whole weekend, as opposed to having to take a pill every single day from that standpoint. So that's a lot better for some patients. But really that'll kind of be the biggest things to look at, so we'll look more specifically at the side effects in just a few minutes. So Again, phosphodiesterase inhibitors should be first-line therapy, especially for younger patients who don't have a big med list or a lot of other comorbid conditions. It is very discreet because you just pop a pill; it's pretty easy. And your selection should really be dictated by either the adverse effects, the onset of action that you're looking for, the duration of treatment, and then the cost of it, and how which one is particularly covered by their insurance if they have it, or if they're paying with cash out of pocket. You'll find that most patients will respond to this around 50 to 80%, and usually poor responders are more likely to have comorbid conditions. They may have diabetes, they may have other problems that are kind of compounding this and making it more difficult for the drugs to work. As far as therapeutic failures go, it's important to look at things like food interactions, so whether or not they are, sometimes eating with fatty foods can sometimes help with absorption, so things like that. So make sure you can counsel on that for those particular drugs, sildenafil and vardenafil. And patients typically should try around 5 to 8 doses or so to see how they're going to respond to it. If they're having some minimal response, you can try titrating your dose up, or particularly switch over to a different agent. One thing to always kind of counsel them to try avoiding is excess alcohol, because obviously that can have some negative effects just by depressing their CNS. So, and then it should be avoided, obviously, in healthy patients, patients with sickle cell, leukemias, multiple myeloma, or other erectile dysfunction therapies. You really don't want to be combining this with other medications because we run the risk of priapism occurring. And so that's why I always say if you have an erection for more than 4 hours, call your doctor, because that's a urologic emergency at that point. So again, looking at the other PDE isoenzymes that you can run across, PDE6 is mainly found in the rods and cones of the eye. So this is why you see the side effect of blurred vision and cyanopsia. Do you guys know what cyanopsia is? It's kind of bluing of the vision, right? And so you think about sildenafil having more activity against PDE6, and so that's why you think of the blue pill causes kind of blue vision, is how I think about it. Typically, you're going to find sildenafil has the most activity for this. Vardenafil and avenafil are kind of equal from that standpoint, and then tadalafil has the least amount of effects affecting PDE6. So again, this is one of the things where patients says, "Oh, I took it; it was great, except for everything looked blue." Okay, well, let's try switching off of this and over to, like, say, tadalafil. That would have much less activity there. And then you're going to find that PDE11 is going to be affecting the striated muscle, and so this leads to a lot of myalgias. And tadalafil has the greatest affinity for these these patients. It's actually kind of interesting. One of the we do a lot of different types of research projects over at Nemours, specifically with some of our neurology kids. And so one of the things they were looking at was using for kids with Duchenne's muscular dystrophy, actually using tadalafil because it was affecting this PDE11 to see if it actually helped with things like walk times and whatnot. It actually found not to be effective, but it's interesting how we were finding other uses for these drugs based on their affinity for these other enzymes. So you may see other uses for these drugs as you move forward in your careers. So, looking at the onset, typically these drugs are going to have, they kind of have to guess when things are going to be happening for them. So again, think about 1 to 2 hours before they're expected to have intercourse. Basically, you can have slowed onset of action if consumed within 2 hours of food, especially for sildenafil and vardenafil. So just let them know that if they're having it with dinner, like it's going to take a little bit longer to work. Tadalafil is a little bit slower onset, but it is going to be lasting for around 36 hours. So you can get most of the weekend covered with that medication. As far as metabolism goes, you're going to find that these are metabolized somewhat by CYP3A4, so you can have increased levels if you have an inhibitor on board, so it's important to look for those drug interactions. And then sildenafil and tadalafil should be renally adjusted if you have patients who have poor renal function. Okay, so the main side effects you're going to run into with these drugs are going to be related back to not only which kind of isoenzymes the PDE they're affecting, but also the fact that they're affecting blood flow, not only to the sexual organs, but also to other places. So you'll see headache, right? Because anytime you see vasodilation in the cerebral vasculature, just like we saw with migraines, the same thing happens here. They get facial flushing, dyspepsia, nasal congestion, dizziness. All those are fairly common side effects you can see with this. It's dose related, so sometimes they can get around that by kind of decreasing their dose, and they'll be a little bit more manageable for them. You will see a drop in their systolic blood pressure. Most patients are going to end up being asymptomatic from this, but you do want to avoid patients who are on multiple antihypertensives or nitrates. Nitrates is going to be a big contraindication for these patients receiving phosphodiesterase inhibitors. But make sure you use cautiously or not at all in high-risk cardiac patients, especially if they're really dependent on having that blood pressure to maintain blood flow to the heart. Otherwise, you can potentially end up precipitating an MI or something like that. So other adverse effects you're going to expect to see includes photophobia, blurred vision, loss of that blue-green color discrimination. So that's that synopsia we're talking about. Again, that's related back to PDE6 inhibition in the eyes. Generally is going to be reversible, but there's this one side effect you really should be concerned about if you hear this. So this non-arteritic interior ischemic optic neuropathy, or NAION, and basically this is a sudden unilateral kind of just blindness, and it could be irreversible in some cases. Can occur, say, 6 hours after use of the drug, or years the patient's been on it and tolerating. It can happen at any point. Basically, this is related back to a drop in blood flow to the optic nerve. So if they have a little bit of blurry vision, that's not really a problem, but they have like sudden blindness, like that should be stop taking the medication, come in and get checked out, see what it can do for them. Mentioned tadalafil is going to be causing the most effect on PDE11, so this is where you can see some myalgias related to this, or around up to a third of patients may experience this. And then uniquely, vardenafil can cause QTc prolongation, so you do want to be careful. This is mixed with other medications that can do that as well. And obviously, priapism is going to be the big thing you're also going to be educating on. So again, it's rare. Usually, it's going to be associated with higher doses, or if you're using concomitant other erectogenic medications. So if you're using something like prostaglandin plus PDE inhibitor, or if you're using a PDE inhibitor plus a vacuum device or something like that, you're more likely to see priapism occur. All right, so drug interactions occurring here. So nitrates, you can definitely see, because again, nitrates are usually working by donating nitric oxide, and then these drugs are working by inhibiting cyclo-GMP. It's increasing levels of cyclo-GMP by inhibiting phosphodiesterase. So they have a very synergistic mechanisms of action. And so you can see severe hypotension associated with this. And so this is why we do not mix these medications, especially because a lot of our nitrates are going to be long-acting products. Again, so they may have taken, their isosorbide dinitrate or something, this morning, and now they're taking their sildenafil at nighttime. They can still see those effects from that standpoint. So you should be contraindicated. That's a good point to remember. Basically, no nitrates for 24 hours after the phosphodiesterase inhibitor use, or 48 hours after tadalafil, again, because that one has the extended duration of action. Basically, if you have a patient who starts developing angina, which again could be a side effect of activities that they're performing while on one of these medications, they really should be using other agents. So again, aspirin's okay, oxygen, morphine's all fine, but you really don't want to give them nitrates, because again, that can lead to drops in blood pressure, which can impair blood flow to the heart. All could be bad things. Basically, you can end up putting them, one thing is useful to put them in the Trendelenburg position and then give them fluids. You guys know what the Trendelenburg position is? Head down, feet up, right? So that way you can get more blood flow to the head and the heart. Good. And then with your, if you have concomitant CYP3A4 inhibitors, again, start low dose of the phosphodiesterase inhibitor and kind of gently titrate the dose up to see how they tolerate it. Okay. Next, we have the prostaglandins. Usually, alprostadil is going to be the main drug being used here. Basically, it's prostaglandin E1, and you'll see these drugs are given as an intracavernosal injection. This is Caverject or Edex are the two brand names, and then there is one that is an intraurethral insert. Basically, it is it will be applied directly into the urethra. It's kind of like a little capsule kind of looking thing. It's called MUSE, or the Medicated Urethral System for Erection. So, kind of interesting acronym there. Basically, here, instead of working on inhibiting phosphodiesterase and increasing cyclic GMP, this is working to increase cyclic AMP, because it will actually stimulate adenylyl cyclase. That will decrease intracellular calcium and lead to that smooth muscle relaxation that we're looking for. Because this is not nitric oxide dependent, this means that it's good for patients who either have an impaired nitric oxide pathway, for instance, they had a prostatectomy, or if they had diabetes, or if they are on, say, like a long-acting nitrate. This is a good drug to use for them because they don't have that interaction there. You'll find that the intracavernosal injections are going to be more efficacious than the intraurethral. That is very good bioavailability since you're injecting it directly, and usually it's going to be preferred over other types of intracavernosal agents. I'm not going to talk about these too much. We have drugs like papaverine, phentolamine. They've been used in the past, but they're not really as effective as this is going to be. You're also going to find less risk of things like prolonged erections and priapism when you're using these prostaglandins. These are very, very effective, around 70 to 90%. You can see the dose is fairly small there, and then the mean duration of action is fairly short as well. The prostaglandins get broken down very quickly, so it's around 45 minutes or so you should get your duration of action. So again, if you have something more of a kind of a psychogenic erectile dysfunction, this usually responds at lower doses than if it was more kind of vasculogenic. So it could be one thing to remember depending on the etiology for your patient's ED. And then tolerance does not appear to develop, so this drug can be useful for long periods of time. It's not like they would have to switch off of this at some point due to tolerance. As far as discontinuation, it's not often due to lack of efficacy, because obviously it works fairly well, but it could be related back to either inconvenience. If they have a needle phobia, I know that I would be very, very scared if I had to inject myself. This could be loss of interest, cost of therapy. This is probably going to be more expensive than a lot of your other, a lot of like phosphodiesterase inhibitors and whatnot. Other reasons possibly, but this is the main thing. It's usually not because it doesn't work, maybe because of other associated reasons. So basically, it should only be injected into one of the cavernosa, so either one side or the other. And again, durations more than an hour, not really to be expected with this drug because it gets quickly metabolized. You'll see that mainly this drug has pretty limited systemic side effects because it has about a half-life of a minute. So it'll kind of get in there, have its effects, get metabolized, and not really affect anywhere else in the body, which is a good thing. Again, looking at when you're going to administer it, usually about 5 to 10 minutes prior to intercourse. And you're going to be using a high-gauge needle here, hopefully it's as thin as possible in order to inject that. Big things to remember as well is make sure they're using aseptic technique, make sure they're sterilizing the site, washing their hands, all that good stuff. So adverse effects you can expect to see. Usually these are going to improve as you get more used to it and get better at using the injection techniques. You can end up seeing plaques or these fibrotic areas in some patients, and basically those are reversible. You just kind of hold injections until those kind of go away, or potentially use another site. And then pain obviously is going to be the big thing here. So burning, discomfort, dull pain can be related back to the injection itself. Priapism is fairly rare, but it could be another risk you run with this one. But it's nice because these drugs have a short duration of action, less likely to see it than you may with some of the PDE inhibitors. Again, when you have the intraurethral injection, again, this will be placed directly in the urethra. You do run the risk of urethral damage, so it's where you can see issues with strictures or difficulty voiding. So again, that'll be one of those things where if they notice changes in their urination patterns, things like that, they should let you know about it. And then finally, you can have some prostheses. I always think of these as kind of being like a Barbie leg. Like you can bend the Barbie leg and it kind of stays in whatever position you put it in. Was I the only boy that played with Barbies when I was a kid? Anyway, I'm sure you've seen toys like that. Basically, you can either have ones that are malleable, like I mentioned, or the inflatable kind. Usually, these are when patients have failed kind of everything else, and these are going to be more kind of surgically implanted. Usually, very satisfied most patients are, and then infection usually being the most common adverse effect you see with that. So again, this being the most invasive, so be kind of related to those patients that have failed everything else. Okay, so any questions on erectile dysfunction? Using your pump there.
So the penile prosthesis, what are they? They're actually putting something inside to support it?
Yes, I'm not sure about the full details of where it gets put at specifically, but that's usually at the point when I'm reading where I'm like, I don't want to look at this anymore. Yep. There's Google out there, and I'm sure they would have a plethora of information for you to check out.
Google Images.
Google Images, yeah. Okay, anywho, so we'll continue on talking about benign prostatic hyperplasia. So, again, this is going to be the most common benign neoplasm in American men, and it's usually ubiquitous in older men. And so we'll look at the medical management for this. In some patients, you'll use just kind of watchful waiting approaches, and then we'll look at things like alpha-1 antagonists. We'll look at 5-alpha reductase inhibitors. PDE inhibitors can sometimes be used here, anticholinergics, and then finally surgery. Obviously, if the prostate is just not treated with anything else, just chop it right out, right? Hopefully, we have drugs that work before that. But again, looking at based on autopsy studies, they find that this is a pretty common thing to see, especially in older men, and most men are going to develop some enlarged prostate at some point in their life. You'll find that half of the symptomatic patients that have problems with this are eventually going to require treatment, and usually you're going to see this peak incidence around 65 years of age or so. And then around 60% of men, at least 60 years old, develop this clinical BPH, where we're actually having to treat it with some degree of medication. So basically, this is a chestnut-sized gland that surrounds the urethra below the urinary bladder, so you can see the prostate here. And so typical weight can be anywhere between 15 to 20 grams, but you can see this obviously get much more enlarged than that as the patient gets older and develops this. Basically, the function of the prostate here is to secrete fluids that make up some of the ejaculate volume, and then also they provide some antibacterial secretions. A lot of it's due to its high zinc concentrations there. You're going to notice the first kind of growth spurt of the prostate occurs around puberty, and then usually gets another growth spurt around 40 years of age and continues on from there. This will be important looking at the different types of tissues here, because this will dictate what type of medications we can use to treat that. So you can see the epithelial or glandular tissue. This is the one producing secretions, and is going to be stimulated by androgens. So if you have higher testosterone levels leading to higher DHT levels, or dihydrotestosterone, that's going to lead to further growth of that tissue. You have the stromal tissue, or the smooth muscle tissue, and this is embedded with alpha-1 adrenergic receptors. So as you agonize those alpha-1 receptors, they constrict or dilate. Usually constrict, right? Alpha is a constrictive effect, so if you agonize those, you can see kind of clamping down, which is where you can see that problem, because if it clamps down in the urethra, then obviously you're going to have problems with urinary flow. Usually you're going to see stromal to epithelial tissue occur in about a 2-to-1 ratio from that standpoint. And then you have this capsule, which is the fibrous connective tissue, and along with some smooth muscle, and this is mainly going to be containing adrenergic receptors affecting that. So again, we can already start to see where some of our medications are going to be working at different tissue types. So, as I mentioned previously, testosterone gets converted to 5-alpha reductase to this dihydrotestosterone, or DHT. This is where we see things like hair growth and acne. Again, it's more potent than testosterone, and it's going to induce that prostate enlargement. So, already you can see one of our sites for action here is by blocking conversion of testosterone to DHT. So, some drugs that affect that. And again, estrogen can be effective here as well to cause some stromal growth by producing some androgen metabolism. So basically, androgen gets metabolized by aromatase, turned over to estrogen, and that can have some stromal growth effects there as well. So look at a couple of different factors here as far as the pathophysiology goes. So you have the static factors. So this is where basically the prostatic enlargement is physically impinging on the bladder neck. So it's going to be directly obstructing urinary blood flow. And so this enlargement is mainly going to be due to androgen stimulation on the epithelial tissue, and then estrogen stimulation on the stromal tissue. And then you can have some dynamic factors, and this is going to be obviously can get better or worse depending on what's going on because it is dynamic. This is going to be related back to excessive alpha adrenergic tone on the stromal tissue, bladder, neck, posterior urethra, all of that. And this is where it can be triggered by things like stress or pain. All of that can lead to your sympathetic nervous system getting kind of kicked up and leading to that constriction there. So. Basically, symptoms from the static and or dynamic factors, you'll normally notice things like obstruction with a normal prostate size. If you see a normal prostate size and having obstruction, it's usually related to the dynamic factors or too much squeeze from the alpha receptors. If it's in a large prostate, it could be both due to static and dynamic factors. And that'll be important when we're looking at what types of medications we're going to use to treat these patients. Basically, moderate to severe voiding symptoms usually going to be related directly back to increasing prostate size. Okay, so medication-related symptoms, so things that can potentially lead to further problems with this. If you have testosterone replacements, obviously you're giving more substrate for 5-alpha reductase to convert over to DHT, so that can worsen your BPH. If you have adrenergic agonists, this can affect those dynamic factors and lead to impingement there. So pseudoephedrine, ephedrine, phenylephrine, all of those things can lead to further constriction. And then anticholinergic drugs as well. This is more related to urinary retention, since it is causing decreasing constriction of the detrusor muscle on the bladder. So that is just kind of affecting it via a different mechanism here. But first generation antihistamines, phenothiazines, TCAs can all affect that as well due to the anticholinergic effects you're seeing there. Looking at the symptoms you see, so if it's an obstructive kind of pattern, you're going to have prostatism, or as bladder outlet obstruction, and this is decreased urinary flow rate. Bladder emptying is usually incomplete or it's pretty slow, and you can have the patient be complaining of things like urinary hesitancy. You can see some bladder overdistension occurring there. So again, that's where basically you're just having this obstructive issue here. You can have some irritative symptoms as well. This occurs more in the later courses of disease. This is related back to long-standing bladder neck obstruction, and so you can actually see the bladder muscle starts to hypertrophy, and it becomes really hypersensitive and ineffective at storing urine at that point. And so even small amounts of urine can induce a voiding response, which means you're going to have a lot of urinary frequency and urgency. You can have things like bedwetting, clothes wetting, and also nocturia occurring here as well. So symptoms may not always be progressive for these patients. About a half to a third of men usually stabilizing, or they improve without treatment over several years. But if you end up having this lower urinary tract symptoms or LUTs, you can end up seeing issues with neurogenic bladder or UTIs that can develop over time. Some other issues that can come about from this, complications. If you have an acute urinary retention, that can lead to acute renal failure. You guys remember what type of renal failure that would be? Be acute, intrinsic, or post-renal? Be post-renal, right? Because you're causing an obstruction. Basically, you're just having all this backflow into the kidney. Hematuria can occur when tissue growth really exceeds the blood supply, so you can start to see that. You have an overflow urinary incontinence, recurrent UTI. You have bladder diverticulum, all kinds of other problems that are coming about from this obstruction of urinary flow. So how are we going to treat this? So you start out with your patient with BPH, and you kind of you determine what type of symptoms they're really having. If it's pretty mild for the most part, watchful waiting can be a good approach here to see if they are one of the spontaneous improvers or if they're going to have more progressive problems. For moderate symptoms, we're going to see that if they have erectile dysfunction concomitantly, this is where we can use some of our medications like alpha adrenergic antagonists. We can use phosphodiesterase inhibitors or both. If they have a small prostate with a low PSA, this is going to be related more to those dynamic factors, and so this is where alpha adrenergic antagonists will be most useful. If they have a large prostate and increased PSA, this is where we can use things like 5-alpha reductase inhibitors. And then if they have predominant irritate avoiding symptoms, we're going to use more of our anticholinergics. Okay, so we'll kind of go into more into detail on those as we go forward. And then if you have the most severe symptoms, they're not responding to medications, this is where we look at using surgery in order to help remove tissue or get rid of it completely. So the desire here is to reduce those kind of late complications of BPH, hopefully prevent any kind of disease complications occurring, like you mentioned, like the renal failure and things like that, and reduce the need for surgical intervention. So less people going to surgery, the better it's going to be for us. And then obviously our therapy should be well tolerated and cost effective. Any questions from the first half of the class? Okay, so going back to our pharmacologic therapy for BPH, so a couple different ways our medications will be working. The first one is our prostatic smooth muscle relaxers. These are going to be good for reducing those dynamic factors. Again, those can change over time as you get those kind of stressors, increasing that sympathetic nervous system effects. Mainly, you're going to be seeing the alpha-1 adrenergic antagonist being used most commonly here. Okay, does not actually decrease the prostate size. This only affects the actual squeeze that the prostate is going to have on the urethra. If you'd like to reduce the testosterone stimulatory effects, this is where we're going to use our 5-alpha reductase inhibitors, and these are going to be good for reducing those static factors, right? So again, if they have a small prostate and they're still having symptoms of BPH, these would not probably be the best medications for that. Usually, you're going to go with the alpha-1 antagonist. And then agents that can relax the bladder detrusor muscle, these would be your antimuscarinics, and those help to reduce those irritable avoiding symptoms. So look at the agent selection, really should be determined on a case-by-case basis, and then the medications are only going to be providing benefit as long as they're being taken by the patient. So it's not going to be one of those things where, especially if they have enlarged prostates, due to the testosterone effects, as soon as they stop taking the 5-alpha reductase inhibitors, that testosterone effect comes back, you can see the same enlargement occur here. So it's not like it's going to be take it for a period of time, you're off of it, and you're done. You're generally going to come back. For the most part, you're going to be seeing the alpha-1 antagonists having the best effects here, the most rapid acting effects, and the fewest side effects, right? Because again, you're not affecting any kind of hormones in the body. But on the other hand, you can affect some cardiovascular patients by blocking alpha receptors. So by using a 5-alpha reductase inhibitor, that's going to be better for your CV patients, or if they have a significantly enlarged prostate. Again, combination therapy can be warranted in certain cases. They're having kind of issues of both dynamic and static factors. So patients with erectile dysfunction and BPH, PDE inhibitors can be a good first-line agent. Usually it's going to be less effective than the alpha-1 antagonist, but it can have some positive effect here. And in patients with the mostly irritative symptoms, anticholinergics can be added on to other therapies. So it can be a good adjuvant therapy, especially if they've been on these medications or they've had BPH for a long period of time. Add on anticholinergic to help with that. But again, make sure the patient does not have a high post-void residual. Why do you think that is? Because the anticholinergics do cause urinary retention, right? So again, they're going to be holding on to more of that. So again, that would be one thing that may lead you not to use an anticholinergic. So the alpha-1 adrenergic antagonist that we have here, we have a couple of different generations. The first generation is going to be phenoxybenzamine. This is an old drug we don't really use anymore, but one of the big things you can see here, and this is kind of endemic to alpha-1 antagonists, is that when you cause relaxation of vascular smooth muscle, you're decreasing your blood pressure, right? You're going to have that kind of vasodilation, like similar to what you see with the dihydropyridines. What does the heart want to do in response to that? So the heart wants to raise blood pressure. How's it going to do that? It beats faster. It's going to try to increase contractility, so you end up having that reflex of tachycardia. And so especially with phenoxybenzamine, it's a pretty potent agent, but what we end up seeing is a lot of tachycardia and then the risk for arrhythmia is developing with that. So we don't really like to see that. The second generation are going to be even more specific, and they have really no alpha-2 antagonism. Again, with phenoxybenzamine, it wasn't very specific, so it would affect both alpha-1, causing vasodilation, but also antagonize alpha-2 receptors, which could lead to increased norepinephrine release, which could have exacerbated the tachycardia and the arrhythmias. So we prefer using second generation agents. And then kind of the newest ones are going to be the uroselective or alpha-1A adrenergic receptor antagonists. These are third generation. These are ones that are very specific for the types of alpha receptors you find in the prostate primarily. And so alpha-1A are the ones we're going to be targeting with that one. So again, as you get more specific, you see less systemic side effects, which are going to be better for our patients. So as far as efficacy goes, second and third generation are pretty much equally effective, but the third generation has fewer side effects, as I mentioned. And again, these are going to have no effect on prostate size, right? Only going to be affecting those dynamic factors. So the second generation agents that we'll see include prazosin, terazosin, doxazosin, alfuzosin. Probably the alfuzosin has a little bit more kind of selectivity for the prostate muscle itself, but these are the second generation agents. Here you will see potential risk for things like first dose syncope, because again it's going to be causing drops in your blood pressure. They may have, especially older patients who have kind of poor hemodynamic reserve, they may get up and then not really be able to compensate that well for that. So orthostatic hypotension is a big one, and dizziness is very common to see with these medications. In the second generation agents, you really want to start slow and titrate up over several weeks, especially if they have a history of cardiovascular disease, especially if they have risk for kind of having that poor hemodynamic reserve. And then typically you dose it at bedtime. Why do you think that is? Yeah, hopefully they're not going to be getting up as much. Hopefully they'll if they have dizziness and things like that, they'll just kind of sleep through it. You'll see it have synergistic effects with other antihypertensives. So if their blood pressure is maybe not being well controlled otherwise, this can actually help that out because it will cause that vasodilation to occur. Usually we don't like prazosin because it's going to be dosed more frequently, can cause more significant cardiovascular effects. We don't like that one so much. But doxazosin and alfuzosin are better because they're longer acting. And you typically can get away with using lower concentrations, so you see less side effects associated with that. And then alfuzosin probably is the lowest incident out of the bunch, so this is kind of the one that a lot of people like to go with from that standpoint. Really, you don't need a lot of dose titration with this one because you see so few systemic side effects. The third generation agents, so these are going to be, again, they were starting to come off patent and things like that, so you're starting to see these become more affordable. But these again are very specific for the alpha-1A adrenergic receptor. So you have things like your Flomax or tamsulosin, and you have silodosin or Rapaflo. Again, these are so specific; they really lack a lot of the systemic side effects. So tamsulosin, important to know to avoid an sulfa allergy, and should be taken on an empty stomach to make sure you aid absorption effectively. This Rapaflo is not used very often. There's a lot of drug interaction, so from that standpoint, I've never actually seen it being used. Really, tamsulosin and Flomax, that's the main one we usually go with. But other things you can see with this, again, very little hypotension, but maybe some flu-like symptoms, some nasal congestion, and then anejaculation is a rare side effect there. And then, as we mentioned, you can use PDE inhibitors, especially if your patient has erectile dysfunction. You will see synergistic effects on dropping blood pressure if you use these two drugs together, so an alpha-1 blocker, especially a second generation plus a PDE inhibitor. But you're going to see the least likely for this to occur is with tadalafil and tamsulosin. That's usually, if you get your T's together, and that's usually at least likely to have those kind of problems. And then looking at your 5-alpha reductase inhibitors, again, these are going to be better for the static factors here. So these are going to be preventing that conversion from testosterone over to the more potent DHT. So you have higher testosterone levels, but less of it's being converted to that more potent form. So you can have finasteride. Again, this is going to be affecting this type 2 5-alpha reductase. Again, that's mainly the type that you're going to find in the prostate. Will decrease THT levels in the prostate by around 80 to 90%, and about 70% reduction in the serum as well. So pretty potent agent there. You also have dutasteride or Avodart, and this is a non-selective inhibitor, and this will have kind of more pronounced effects on systemic DHT, so about 90% reduction there. This is better for enlarged prostates, so say like greater than 40 grams. It may actually slow disease progression and complications. So you should have some reversal there. You should see some shrinking of the prostate when you're giving these medications. Both of them are going to be equally efficacious, but you're more likely to see systemic effects by using the dutasteride. So again, these are going to be good for patients who maybe can't tolerate the alpha-1 antagonist, but they can be used in combination. So if they're having both dynamic and static factors, these can be used together. And you should reduce the prostate size by about 25% or so. It's actually been seen to reduce prevalence of prostate cancer over time. So again, that can be a good thing for your patients. Problems you're going to see with these drugs is it takes time to work, right? Because you're blocking conversion of testosterone to DHT, it's not going to shrink the prostate immediately. Because again, hormones always take time to work, and you will see higher incidence of side effects, sexual side effects particularly, mainly because you're decreasing, that active androgen, having less libido, more libido problems, and should be second line for sexually active males. Alpha-1 antagonists should really be used more frequently for those patients. 5-alpha reductase inhibitors, as far as long-term use goes, again, prostate size and symptoms will return to baseline once they stop therapy. So again, it'll go right back to where it was, since they will still have that same amount of DHT being formed after that. And as far as sexual dysfunction goes, ejaculation disorders are going to be related back to those prostatic secretions. So again, if you are inhibiting the DHT effect on that, you have less of the secretions, which can lead to those ejaculation disorders. As far as erectile dysfunction goes, it could be related back to issues with nitric oxide, but that's probably not fully elucidated yet. But certainly you see decreases in libido related back to lower DHT levels. Other things you're going to see, nausea, abdominal pain, headache, and gynecomastia can be related back to those having kind of a more estrogen effects related to that. It's important to note this is going to be a pregnancy category X drug. They actually recommend that females do not even handle the drug without gloves because of the risk that they could be exposed to it and have effects on a growing fetus. So this is a big one to definitely avoid women handling because of that standpoint. Looking at the phosphodiesterase inhibitors, again, used concurrently in BPH patients with erectile dysfunction. You can see them sometimes counteract the effects of alpha-1 antagonists and the 5-alpha reductase inhibitors. But again, we already know how they work. They prevent that breakdown in cyclic GMP, which can actually lead to some smooth muscle relaxation around the prostate and the bladder neck itself. So that's where we can get some of the benefits we see there with these PD inhibitors. Again, tadalafil is probably the most studied drug, so that's why we like to use that one, since it does have a longer duration of action. Normally, if you were treating a patient with a PD inhibitor, how would you dose it? How do you think? Like, how often would you give it? Yeah, it should be as needed. Well, for erectile dysfunction, it should be as needed. This would be a more consistent dosing, so maybe like every day you'd be taking this medication. Again, you may have somewhat of an increased risk for priapism, but that is something that could be kind of, kind of weigh the risk versus the benefits for your patients based on that. All right. Then the anticholinergic symptoms. These are going to be more useful for the irritative symptoms. Basically, this is kind of mimicking like an overactive bladder. We'll talk about that in just a little bit. But again, start with lower doses and hopefully to prevent these side effects. Again, think about all the other anticholinergic side effects you're going to see with these, including things like altered mental status for older patients, things like that. And again, make sure they don't have any of that major post-void residual. Otherwise, you're going to see more urinary retention, and that can be problematic. We'll talk more about those agents that fall in this category a little bit later. And then, of course, you could have surgical intervention. Obviously, the gold standard is just have prostatectomy. These are going to be better for moderate to severe symptoms. They're really unresponsive to drug therapy, and will have to deal with the complications of BPH. All right. So then finally, urinary incontinence. Hope you guys went to the bathroom, so you don't have to worry about this right now, right? Okay. So again, this is going to be the involuntary leakage of urine. It can be related back to urgency, and you can see increased daytime frequency and also nocturia occurring here. Leads to things like self-esteem issues, depression, etc., and on down the line. So peak incidence usually occurs in females. So again, I'm trying to shift it and give the females a little bit more attention now. Usually around the time of menopause, we're going to see the most kind of common incidence of this. Around 38% of women greater than 60 years of age are estimated to suffer from this. And chronic urinary incontinence can actually lead to institutionalization of a lot of elderly patients. So again, if they're just not able to kind of control themselves and whatnot, like, it could be one of the reasons, like, well, let's go ahead and move them into kind of more of like an assisted care facility, things like that. So looking at the lower urinary tracts, we're going to be focusing on the bladder, the urethra, the urethral sphincter, and then surrounding structures, and also the urothelium, or the epithelial cells there. And then also we're going to be focusing on this neurophysiology of the detrusor muscle, which is innervating that parasympathetic, or innervated with parasympathetic fibers. So acetylcholine is going to be the main neurotransmitter that's affecting this, and mainly it's going to be these muscarinic M2 and M3 receptors here. M2 is probably a little bit more prevalent, but M3 is going to be more responsible for the UI symptoms for these patients. Okay, so again, if you activate those muscarinic receptors, what happens to the urinary tract? Does it stimulate or inhibit it? Should stimulate it, right? So as your parasympathetic nervous system gets activated, you're going to cause the detrusor muscle to constrict down. It's going to cause urination to occur. So very similar to what we saw if you had like an organophosphate exposure in a patient and they were to have too much acetylcholine in the system. Usually you see urinary incontinence and diuresis occur there. So anyway, so the urethral sphincter should retain adequate closure. If you were to have, you'll see that the proximal sphincter is going to be involuntary, so it's not really controlled by us, but the distal sphincter is voluntary, so the patient has some control over that. Look at the bladder. This should be accommodating the increased volume without increasing the pressure. Usually if you have problems with the detrusor muscle not being relaxed enough, that's where you can have the issues where increased volumes are going to lead to that more pressure and more urinary urgency. And then compliance is going to be accompanied by that smooth muscle relaxation, so that's going to be the big thing we're focusing on from that standpoint. And there really needs to be a coordinated effort between the organs, and so if you have any kind of disruptions in neuroregulation between either the brain to the spinal cord to the pelvic nerves, that can all lead to dysregulation there and lead to incontinence. So a couple different types. So you can have stress urinary incontinence. This is going to be related back to urethral underactivity. This is going to be UI seen with like a brief spurt of activity. So you can see things like exercise, sneezing, etc. Anything like that can lead to those kind of increases in pressure and lead to some small amount of incontinence. Basically, this can be related back to inadequate closure pressures of those sphincters. Usually, it's going to be low volume leakage, usually episodic. So really, patients will kind of know specifically what will trigger them. Risk factors include things like childbirth and pregnancy, since that can cause lots of, childbirth itself can cause lots of changes down there. Menopause, obesity, aging, all of that can lead to closure issues of those sphincters. Usually it's pretty rare in men, maybe seen with surgery, but it's usually going to be more found in females. And it can be aggravated by drugs. So we know that alpha antagonists, like we mentioned for use in BPH, that can cause smooth muscle relaxation, so that can be problematic. And then actually ACE inhibitors and ARBs, if you remember, can cause cough due to increases in what product? Not leukotrienes. Well, substance P related back to bradykinin. Remember bradykinin? Maybe? No? Okay. Go back and review the slides. But bradykinin is really important for causing ACE inhibitor or ARB cough. And so that's what can lead to some of this stress incontinence. If you have urge urinary incontinence, and this is related to bladder overactivity. So this is leakage associated with urgency or the desire to void, and it's usually related back to this detrusor overactivity due to these involuntary contractions, right? So the patient, it's not a problem the sphincter is not closing; it's more of a factor of the bladder not being relaxed enough. This is not overactive bladder, so it's not necessarily frequency. It's really just that urgency that really responding to that pressure that's building up there. Can be idiopathic. You can see neurogenic detrusor overactivity. So this can be occurring with things like neurologic disease, bladder outlet obstruction, but this can be worsened by things like diuretics and alcohol. Why do you think that? Cause urinary volume to go up, right? How does alcohol cause diuresis? Yeah, it inhibits ADH, right? So anything increasing the amount of urinary flow you're having there is going to be leading to increased pressure in the bladder, which can lead to these urge urinary incontinence. So you can also have a overflow incontinence, and so this is going to be related to urethral overactivity and or bladder underactivity. So this could be leakage due to a filled bladder that's unable to empty, and so it's related back to frequently to chronic urinary retention. Usually with urethral hyperactivity, this is more commonly seen in BPH with men because again they're having that prostate kind of impinging there. But you can also see it with neurologic diseases. So if you have like MS or spinal cord injuries, that can be causing this as well. As far as bladder underactivity goes, basically the bladder cannot empty completely, and so you can see this is a long-term either outlet obstruction or sometimes diabetes, related back to those neuropathies you can have developing there, so that can be a cause as well. So it could be one or either of these, or it could be both in these cases. Then as far as medications that can cause urethral hyperactivity, you can see things like TCAs causing this, or alpha agonists causing constriction there. And then medications that can decrease bladder contractility will include our anticholinergics, TCAs, calcium channel blockers can do this in some cases, and other antipsychotics as well can all be affecting this. Mainly back to the anticholinergic effects. Calcium channel blockers are just more related to the smooth muscle relaxing effects that those drugs have. So how these patients are going to present is going to depend on their underlying pathophysiology. So again, if they have like urethral underactivity, they should have some leakage with physical exertion. If it's bladder overactivity, should have urinary frequency, say like greater than 8 times a day, or it should have some urgency associated with it. And then with overflow incontinence, should have lower abdominal fullness, hesitancy, and it's incomplete bladder emptying. And with that one, you may either have frequency and urgency associated with it. So it'll be important. It's going to depend on what type of drugs we're going to use in order to treat these. But basically, the course of therapy is going to be dependent on specifically what was kind of bothering the patient. So if it's the volume that they're having, if it's the frequency, obviously use of things like absorbent pads. Like they may not want to have to use things like that in order to combat this. Is where medications might be useful for them. So goals here, we'd like to restore continence, obviously, and re-educate on a reduction of a number of UI episodes that the patient's having, and then hopefully prevent any kind of complications. If you can have like prevention of nursing home placement, things like that, that can be beneficial for the patient, and obviously minimize their adverse effects, costs, and then increase the quality of life for the patients. So generally, you're going to see that drugs are going to be used for patients that are not controlled with non-pharmacologic therapy alone. So oftentimes you're going to see drugs being used along with other non-pharmacologic therapy to help kind of supplement one another. And then the drug selection is going to be based on the UI type and also their other comorbid conditions and what's playing a role here. So as far as non-pharmacologic therapy goes, this should be first line. These are better for more mild to moderate symptoms. Basically, patients, especially if they want to avoid surgery and or using medications, this is a good first stop here. This can include behavioral interventions, lifestyle modifications, especially like timing fluid intake around like bedtime and things like that. Pelvic floor rehabilitation and caregivers, obviously, especially for older patients who are having symptoms of this, should be active and participants in kind of getting all the behavioral stuff down. But for urge urinary incontinence, anticholinergics are going to be our first line here. So these are a list of drugs that we have available that work as anticholinergics, and that hopefully are going to be targeting specifically the bladder muscle to antagonize those muscarinic receptors and allow for the detrusor muscle to relax and allow for better filling of the bladder, allow for better storage. So you have things like oxybutynin, tolterodine. Those are probably some more common ones I see. Notice how those have XL and LA formulations, so they're going to be longer acting ones, so they're better for just taking once a day usually. You have things like solifenacin, darafenacin, which are going to be vesicare and Enablyx. Sometimes you'll see those being used as well. All of them are working very similarly, blocking muscarinic receptors. And all of them are going to be considered pretty much equally effective, just dependent on what is, what dosing schedule is best for your patient, what is covered by their insurance, etc. What's going to be best for that patient. So again, with urge urinary incontinence, this is going to be, you can see anticholinergics are going to be the first line here. Again, many of them are going to have long-acting formulations. Some will have transdermal formulations, which can be good for elderly patients who maybe don't want to remember to take a pill every single day. That can be useful for them. And obviously, adverse reactions are going to be related back to those antimuscarinic effects. You guys remember the mnemonic we use for anticholinergics? As a Hatter. dries a bone, where's the beat, yeah, all that good stuff. So you guys know all that. So again, but keep in mind, by giving the anticholinergic, obviously this is going to try to be a little bit more specific for the urinary tract, but you can still see that in elderly patients, antimuscarinics can be really problemsome because you may see increased, delirium or mental status changes that you have to consider whether or not it's related to the drug or just the progression of their disease. Obviously, contraindications would include if they have urinary retention. You don't want to worsen that by using these drugs. If they have any kind of gastric retention or decreased GI motility, this will be worsened by your antimuscarinics. It's going to slow peristalsis down. Uncontrolled narrow angle glaucoma, because that can worsen that. And then myasthenia gravis can be worsened by this as well. Obviously, that's related back to a lack of acetylcholine being able to affect those receptors. So. Also, you may run the risk of seeing falls, especially in the elderly patients. You want to be careful with that and make sure they're not at risk. So again, oxybutynin and probably tolterodine are probably the most common ones that I see being used. Keep in mind that the longer-acting formulations usually related to or usually have less systemic side effects. Things like dry mouth can be a particularly problemsome one. This is probably the most commonly run into. So again, if you just ever had dry mouth, like it's really uncomfortable for the patients. But with oxybutynin, this one will have some risk for orthostatic hypotension because it does have a little bit of alpha blockade. So again, be aware of that in your elderly patients. And the XL formulations is really important. They do not crush or chew these, mainly because you can have all that drug be released at once and see increased risk for side effects. Tolterodine is one that you do want to avoid in patients that have really poor renal function because that can actually build up and cause some other problems there. And if it's metabolized by CYP3A4s, you want to avoid that in patients that have those interactions or adjust your dose appropriately. Trospium is actually a second-generation anticholinergic. It's a quaternary ammonium, which means it doesn't cross the blood-brain barrier, so you actually have fewer kind of CNS effects than you would see on your some of your older patients, which is a good thing. But again, this one also you should avoid in renal dysfunction, since it will kind of have built-up of levels. Sometimes you will see botulinum toxin can sometimes be used. We mentioned this before, being used for what kind of conditions? Migraines potentially. Obviously, use it to look beautiful forever or look really surprised forever. But you can also use botulinum toxin. Obviously, this is used to, it comes from the Clostridium botulinum. It's going to be able to paralyze that both smooth and striated muscle tissue and prevents that release of acetylcholine. So if you don't have acetylcholine being released, it's not going to have that same kind of squeeze on the bladder itself. So this can be used for refractory or sometimes neurogenic urinary incontinence. This is certainly an off-label use. You may see it used more frequently than that. It actually gets injected directly into the detrusor muscle or into the bladder itself. And it lasts for generally a pretty long time when you inject it locally, so duration of action between 4 to 8 months or so. So if patients have kind of failed a lot of other therapies, this might be a good thing to try for them if they have this urge urinary incontinence. Again, for the most part, you may see kind of too much effect here. You may see urinary retention that can develop due to that, because again, the muscle is paralyzed. It's not going to be working very effectively for that long period of time. So that's for if you had kind of bladder overactivity or kind of too much detrusor muscle activity here. Now for urethral underactivity, we want to use therapies that are going to help to increase urethral closure. And so things that can help us with this include estrogens. So this is thought to encourage proliferation of that urethral epithelium, can help to improve local circulation, and then also actually increase that number and sensitivity of alpha receptors right there in the urethra. So that can be a very positive thing to help increase that closure there. Sometimes you'll use things like transdermal estradiol, conjugated creams, conjugated estrogen vaginal creams, other products like that. We've talked about this previously, so you guys know all the caveats with using those. For instance, like what's the benefit of using like an intravaginally administered product versus say like an oral product? Local, you don't have so much of the liver problems you run into, like increased clotting. Less systemic effects in general, so it's going to all be a good thing here. Progestins actually have an antagonistic effect here, so you'd probably want to use estrogen product by itself. Again, consider if your patient is going to be really candidate for that, whether or not they have an intact uterus and whatnot. Some people may not have a ton of evidence behind it necessarily, but some people will use only the transdermal product. Should be used for urinary incontinence, so that's probably the most frequent one you see being used, like Premarin cream and things like that. You can also use alpha receptor agonists, and so you can use things like phenylpropanolamine previously, but that got removed due to stroke risk. But basically, that was acting as a pure alpha agonist, but due to that, that got removed from the market. Nowadays, we use duloxetine or Cymbalta. You guys remember that being used for what condition? Depression, right? We also use it for a lot of like neurologic condition or neuropathic pain, things like that. But being an SNRI, that's going to increase levels of what neurotransmitter? A little bit of serotonin, but more specifically norepinephrine, right? So you have more norepinephrine, it's going to squeeze down those alpha receptors. So this is thought to help kind of facilitate a bladder to sympathetic reflex pathway, and it helps to increase that urethral tone. So it's going to be approved for more like stress urinary incontinence in Europe only, but certainly may see some off-label use for it here in the U.S. And then we talked about overflow incontinence. So again, go back to looking at the BPH section. Again, we mentioned things like using, especially if it's related back to BPH, using things like your 5-alpha reductase inhibitors, etc. So, any questions on the urology section? If not, okay. So I'll probably, well, let's see how the next week goes. I'll at least do one class as a review. But other than that, that's the end of the material for this section. You guys have any questions? Okay, if not, if you have research questions, feel free to. I'll be in my office for a little bit, so try to come hit me up then. I'll see you guys next week.